Welcome to the webinar, Anxiety and Medical Encounters, Effective Stigma-Free Communication. I'm Barbara Lewis. Thank you for joining us. This webinar will last about 30 minutes, and if you have any questions, you can type them in the Q&A box. If we don't have a chance to get to your question during the webinar, we will respond afterwards. Before we get started, let me briefly talk about DocCom. So DocCom is a proven online interactive healthcare communication skills learning system, and it is very media rich, interactive, and it provides for a lot of knowledge, skills, and attitudes for the learners. The module authors are leading faculty, and we have a great back-end learning management system with assignments, assessment questions, a grading matrix, which is fantastic, lots of resources. There are 42 interactive online modules and over 400 realistic videos, and many of those videos are annotated, which our learners really love. So not only can they watch the video, but they can, and listen to the video, but they can also read what the skills that are being used at the time on the side panel. So you can use DocCom anywhere, anytime. There have been 10 journal articles written about the value of DocCom. We've had over 100,000 subscribers from 20 countries, have been translated into 3 languages, and we have about 90 institutional subscribers. And here are some of the journals that support DocCom with the various articles. So I'm really delighted to introduce our presenters today. Heather Heiman is Associate Dean for Medical Education in Chicago and Associate Professor of Medicine and Medical Education at the University of Illinois College of Medicine. And Sonya Rasminsky is an Associate Professor of Clinical Psychiatry at UCLA and UC Irvine. So Anxiety and Medical Encounters is one of 42 modules on DocCom, and our presenters have recently revised the modules, and those revisions will be posted on DocCom along with new videos very shortly. So welcome, and I'm going to turn it over to you.
Great. So it's a pleasure to be able to present to those of you who are on, and hopefully we can have this be somewhat interactive because we can see your comments in the chat. If you haven't already, let us know. Please let us know what your role is so that we can sort of adapt at how we're talking to you. I know that some of you are involved in CME, GME, and UME. So we'll go ahead and get started. So as is not surprising, anxiety is the most common form of mental illness that we encounter as providers. 20% of US adults are affected by anxiety in some form every year. And basically it occurs young. Almost 75% of patients who have an anxiety disorder will manifest by the age of 22. Anxiety disorder frequently doesn't occur on its own. It occurs often with depression or with comorbid substance abuse. And in primary care, the percentage of people walking into our office, I'm a general internist, the percentage of people walking into our office who have anxiety is quite high, 15 to 20%. And we know that the COVID pandemic has exacerbated anxiety among frontline healthcare workers as well as the general population. Can move forward. So hopefully by the end of this short webinar, you'll be able to describe some of the key features of anxiety and common anxiety disorders, list some of the somatic symptoms that often will lead anxious patients to seek treatment in an office setting, list medical conditions that can sometimes masquerade as anxiety, to elicit the anxious patient's symptoms and perspectives, assess patients for behavioral and somatic comorbid conditions with anxiety, and to be able to use the ask, tell, ask format to inform patients both about how their illness works, how mind-body interactions can produce somatic symptoms, as well as what options they have for treatment to explore whether they're interested in partaking in these options. So we'll do this by a case. So JQ is a 42-year-old man who has a history of hypothyroidism, and he presents to clinic because he's been experiencing intermittent shortness of breath for the past 3 weeks. He notes that the shortness of breath can come at any time of day, but that it is often worst in the evenings when he finishes work. He's a financial analyst and he works from home and lives alone. He's been able to exercise by running 3 miles each morning without any shortness of breath. He doesn't have a cough, a fever, chest pain, or leg swelling. His symptoms began shortly after his supervisor sent an email that his team was going to need to return to work in person starting in a month. He is concerned about having to work in an office with an open floor plan. While he's vaccinated, he fears potential breakthrough infection. So, there are in our experience, Dr. Rasminsky and I put together sort of 3 potential presentations of anxiety that we see and that I often see in primary care. So there are patients who come in and overtly their chief concern is that they are anxious, they are worried, they are fearful. That happens. But perhaps more often, patients will come in describing physical symptoms that you suspect are, or that I suspect are manifestations of anxiety. And there's a third group of patients who present with an illness and they have extreme worry about this illness, either about the illness itself or because they're anxious about getting medical care. So I'm curious if you could put in the chat, what group do you think JQ might belong to? The first group, the second group, or the third group? Okay, I'm looking at the chat. Yeah, the second group. So that was the idea, is that he belongs to that very common second group. So you can move forward. So kind of key principles of working with really in some ways any of these 3 groups are that anxious patients may present in the first way, feeling anxious, nervous, worried, or upset, and or the second way, exhibiting physical symptoms that are manifestations of anxiety. They are reassured that you're taking them seriously when you explore their somatic symptoms carefully. And anxiety is something that you have to watch yourself as a provider for, because it can be catching. A patient who is feeling very anxious can make you, the provider, feel anxious. So it's important to take steps to calm yourself. And those steps are sort of outside of the realm of what we're going to talk about today, but it's something to be aware of. It's important to gently inquire about stressors, as well as to ask about prior symptoms or treatment for an anxiety disorder. So we'll go into this in more detail. The first thing that will be important for JQ, whether he's somebody that I'm seeing for the first time, or whether he's somebody that I'm going to be seeing in an ongoing way, or is someone that I'm seeing just as an acute care visit, is that I use empathy skills. I need to be sure to reflect back to him what I hear him saying, and I can do that in exactly verbatim words, or even sometimes more helpful, I can paraphrase what he's saying. That paraphrasing can promote understanding, showing him that I do understand what he is telling me. Legitimation, both explaining that this is common, normalizing the problem, as well as praising the patient for seeking care for this problem, is important. Showing both your support and that you're going to work with the patient as a partner, no matter whether that'll be a single visit or it will be an ongoing relationship. And then showing respect for the patient in both verbal and nonverbal ways, making sure that you're on their level, that you're seated as you're talking to them, making eye contact really shows respect. I think an important thing with anxiety is to name the emotion, to be able to say, you seem quite tense or you seem quite nervous. That can really help put the patient in a position of feeling very understood and allow them to open up. And as I mentioned earlier, legitimating is really important with anxiety and with other mental health disorders, because there is still so much stigma around these disorders that to tell a patient, many patients I have seen over the last week have been coping with this, particularly during the pandemic, but at all times. Anxiety is one of the most common things I see in medical care, can be very reassuring and affirming to the patient. So in terms of what information I would want to elicit from JQ, I would want to take a complete history. So rather than sort of prematurely closing on anxiety as the possible diagnosis, just because this happened to him right after his boss told him that he would be returning to work, I want to explore in full his chief concern, his associated symptoms. I want to ask about past medical history, and in particular, I want to have my alert up for conditions that could be associated with anxiety, which we'll talk about on a next slide. We'll ask about a past history of mental health problems, and I think it's particularly important to ask that past history of mental health problems in the context of a full and complete history, not as something that you're asking as a one-off to make the patient think that there's something different about the problems because they are anxiety or because they are depression. You want to ask this. It's much easier to ask it as you're gathering the full history. gathering information about all the medications that they're taking, including over-the-counter medications that can provoke anxiety or provoke symptoms that could be confused with anxiety is important. Asking a full family history, both about physical and mental health, is important. And then, of course, the social history is one of the most important things that we can do, and we can collect. Often we don't leave enough time for it because it comes sort of towards the end of the history. Asking the patient gently about stressors, asking them about substances and whether they ever do use substances to help them alleviate anxiety feelings or feelings of concern or worry. Asking them about social determinants is really critical, something we should be asking every patient about: access to healthcare, food, shelter, as well as about their current relationships, and with a particular attention with every patient on the first visit to asking about intimate partner violence. As you're collecting this history, you want to do is make sure that you differentiate anxiety disorders from disorders that are medical conditions or drug effects that either can be completely confused with anxiety or could exacerbate pre-existing anxiety. The patients will appreciate your taking this thorough medical history, and you may find things that you can treat. So thyroid disease, particularly hyperthyroidism with palpitations and diaphoresis, can be confused with anxiety. Heart disease with heart failure or atrial fibrillation leading to shortness of breath or palpitations can be confused with anxiety, as can lung disease like asthma with its shortness of breath. We always think about B12 deficiency in patients who have anxiety or depression to go ahead and check for that and make sure that you don't have something you can easily replete that will at least alleviate things. Seizures, particularly complex partial seizures, might manifest as anxiety. And then alcoholism or drug addiction, whether it is intoxication or withdrawal, can look like anxiety. Particularly, we want to think about medications that can cause anxiety. As we counsel our patients when we begin them on medication for depression, such as an SSRI or an SNRI, there can paradoxically be anxiety that happens in the first several days of being on those medications, something important to think about. Anxiolytics like benzodiazepines can also paradoxically cause anxiety in patients. Insulin, if it is dosed excessively, can cause anxiety. Thyroid hormone in overdose, and this patient does have a history of hypothyroidism, so we would want to ask ourselves some questions about his current TSH and his current thyroid replacement. Can definitely be a cause of anxiety. Oral contraceptives, antihistamines, these can also cause symptoms that can seem like anxiety. So you express empathy for JQ's concern about his shortness of breath and also about his return to work. And you tell him that it has been anxiety provoking for a lot of patients to return to the office. This is legitimating. You remind him that vaccinated individuals are 6 times less likely to get COVID, even with the Delta variant. And you tell him about mask efficacy. You learn that his hypothyroidism is managed with levothyroxine 125 micrograms per day, and a recent TSH was normal. You also find that he did have a history of anxiety in his mid-30s, for which medication and psychotherapy were effective, but he stopped them when he got his new job, and he has felt well since then, up until now. His sister and father have also had problems with anxiety, and you do a physical exam, which shows you all normal findings, including his heart, lungs, and abdomen. So I'm going to turn it over to Dr. Rasminsky now to take us forward in thinking about group 3 patients and then about the further treatment of JQ.
Thank you. And it's so nice to be here with you guys. And I'll talk a little bit about the psychiatric aspects of some of this. You know, I see a slightly different side of anxiety when people finally do get to a psychiatrist, which is a very, very small proportion of the folks who struggle with anxiety. But the group 3 patients who have a lot of anxiety about their illness or about seeking medical care is a huge issue. And, you know, this falls into 3 general categories. The first is anxiety about the illness itself. You know, someone who gets a medical diagnosis or just a lab result. You know, now what we're seeing with labs being released to patients is that people get lab results that are abnormal and kind of freak out and have, you know, a lot of anxiety about what does this mean? What's the prognosis? There can be a lot of concern about one's body, what's going on. People don't necessarily understand the meaning of symptoms and can tend to catastrophize. There can be a lot of fear about pain, fear about suffering, fear about, does this mean that I'm going to die? Does this mean that I'm going to be dependent on my loved ones or be abandoned by my loved ones? And then a concern about the impact of whatever illness on one's identity, one's ability to earn a living, and a concern about the impact of the illness on relationships with friends, with coworkers, with family, and that all of that is kind of wrapped up in what seems like a very simple diagnosis often. The fear about having an illness and this illness anxiety disorders, there's actually been a big change in the DSM with the DSM-5. There used to be a whole category called somatoform disorders, and that was incredibly confusing for primary care physicians. Nobody really understood what that meant, and that's been revised for a few reasons. One is that the stigma of sort of having mental illness be a diagnosis of exclusion, that you would look for a medical cause, and if you couldn't find one, then you would say, well, this is psychosomatic, and that understandably was accompanied with a lot of stigma. And so the DSM now has changed to a category called somatic illness disorders, and it's basically the acknowledgement that there is a somatic symptom, and then that may be accompanied by some anxiety. So the illness anxiety disorder is what used to be known as hypochondriasis. It's the fear of having an illness, usually when the somatic symptoms aren't necessarily in line with such an illness. And then there can be a lot of anxiety about medical care itself, the concern about going to the hospital. And now, we're seeing patients who are terribly fearful about going to the hospital because of concern about catching COVID in the hospital itself. A concern about negative reactions from clinicians. Is this person going to take me seriously? And then we see specific phobias, particularly anxiety about needles, anxiety about getting shots with the vaccines, and anxiety about having blood drawn, that can really keep people out of the hospital. All right, so there's two major psychiatric diagnoses that we're going to talk about. Generalized anxiety and then panic. And these are the ones that we most commonly see in patients. And what you have here on this slide is the GAD-7, which is a common screening tool that is used for diagnosing and then following GAD. It's not actually mapping completely onto the diagnosis, but it does give you a good sense of the diagnosis. And this is a very useful screening tool in primary care because it can be followed over time as a way to see if symptoms are going down. The primary symptom in generalized anxiety is a persistent feeling of anxiety, nervousness about multiple different issues. And a feeling of really not being able to stop that tape from running, not being able to control worry. GAD has built into it somatic symptoms that are not on this list, but very often what you will see is fatigue, difficulty sleeping, trouble concentrating, that can be mistaken by patients often as some other medical illness, and that may be what brings them into the doctor. And then you also see things like difficulty relaxing, restlessness, irritability. That's very often a presenting complaint. And then the fear that something terrible is going to happen. And in the context of illness, often the fear that I'm going to die, or I'm going to get horribly ill, or I'm going to be debilitated. Panic attack and panic disorder often presents in the primary care rather than in the psychiatric setting. Panic attacks are actually very, very common. Most of us have had a panic attack at one time or another. And this is what often brings people not to the psychiatrist, but to the ER, because those symptoms are heart racing, sweating, palpitations, trouble breathing, sensation of choking, chest or abdominal pain, nausea, dizziness, feeling like you're going to pass out, and then a sense of something terrible happening. And very often people present thinking that they're having a heart attack. These symptoms come on very suddenly, out of the blue, generally last about 10 minutes and then recede. And it only becomes an issue, and this is only a diagnosable disorder, when it's recurrent. So panic disorders is recurrent and unexpected panic attacks. And in between those attacks, what happens is that people become either preoccupied with having another attack or start living life in a way to avoid having those attacks. And that's when it becomes an issue. With any psychiatric disorder, it's not a diagnosis unless it's causing social and occupational dysfunction or significant distress. In its worst case scenario, panic disorder can be accompanied by agoraphobia, which means fear of the marketplace. In its worst form, not going out, but just general restriction of activities. Often can be comorbid with either substance use as a way of trying to calm those panic attacks, and comorbid often with other anxiety disorders and also with depression. So in our case of JQ, he scores quite high on the GAD-7. The maximum score is 23, so this is a very high score. He has had a panic attack in the past, but not in the last year, and has no symptoms of depression. So his diagnosis is most likely going to be generalized anxiety rather than one of the other anxiety disorders. So in terms of talking about the diagnosis, patients, and I would say clinicians as well, often have difficulty understanding that the mind and the body kind of work together and create more of a dichotomy than in fact exists. And I think, as a result of that, patients may reject the diagnosis of an anxiety disorder or feel stigmatized by that diagnosis. Very important for clinicians, and I see this as a psychiatrist, that the patients who go to their primary care and have the physical symptoms taken seriously, have that complete evaluation that Dr. Heiman was talking about. It makes a huge difference when those somatic concerns are taken seriously in terms of being able to accept that anxiety is an independent cause of suffering and disability and merits treatment. So the ask, tell, ask approach is one that is very helpful in terms of delivering a diagnosis and starting a treatment plan. So asking about the patient's current knowledge, what do you think is going on? The patient who comes in with a headache and said, or the patient like JQ who may think I have COVID, useful to know what the patient thinks is happening so that you can then address that concern. After asking, you make concrete, brief, and clear tell statements about how you understand the diagnosis. So if you don't think that the person has COVID, then you can explain why you think that that's not true. Maybe the test was negative, maybe they're not particularly high risk, and then why you think an anxiety disorder is the more likely diagnosis. And I think important to acknowledge that there is a stigma, and that that it's okay, that anxiety is very common, and that there are treatment options, and that this is a highly treatable disorder. Again, important to encourage the patient to ask questions and ask, how do you feel about what I've said? What are your thoughts? Any thoughts, questions, concerns, so that it's really a dialogue rather than just the clinician giving their sense of what's going on. Treatment plan needs to be co-constructed. So an unpressured and empathic approach makes all the difference in the world. Exploring the patient's perspective, again, hearing what they think is going on and then sharing information about what you think is going on. Often patients are going to be reluctant to seek treatment. And, I can't tell you the number of times when I've gotten calls from patients who may have gotten the number of the psychiatrist a year ago. So important to explore all kinds of approaches, beginning with self-management approaches, such as things like exercise, meditation, stress management. Exercise is a huge one that I think is often overlooked. Always leaving the door open to future treatment and remaining supportive even when the person isn't choosing the path that you think is most effective or you think would be most beneficial. As Dr. Heiman said before, that being very clear that you're not going to abandon this patient, you're going to continue the conversation at a later date, that this is an ongoing collaborative process. So JQ, somewhat reluctant to consider that this shortness of breath is anxiety, but is willing to pursue treatment and follow up as long as you're willing to keep an open mind. So he started on an SSRI, referred to cognitive behavioral therapy, and then a 6-week follow-up is arranged. And I think it's very important that the primary care stay involved because patients often are very connected and feel abandoned when they're sent off to the psychiatrist, never to be seen again. And so this, during follow-up visits, you would always be monitoring symptoms, monitoring adherence, and addressing barriers. This happens with me all the time, that I'm asking, about what percentage of the time do you think you're taking your medicine? Is it around 50%? And then you get honest answers when you're not judgmental about it. Continuing education about anxiety, about working together, eliciting any adverse events and concerns as they arise. With medication, there can be side effects, important to be open to hearing about those, and important to continually reassess progress, adjust the treatment plan. Following something like the GAD-7 can be useful for the patient to see how they're coming along and for you to see. And then this is kind of far down in here, but I would say considering referral to a mental health professional much earlier on in the course if the person is open to it. And again, always to document informed consent and any changes in the treatment plan. So the 5 A's is something that DocCom has developed, assessing what efforts to control anxiety the patient has already made, advising about information about anxiety or its management, agree, so helping the patient to develop and set specific personal action plan in collaboration with the physician, assisting the patient to develop solutions to barriers to carry out their personal action plan, and arranging follow-up and making sure that's tailored to the patient's specific needs. So in conclusion, there are these 3 major common presentations of anxiety that are seen in primary care. Those who present with their chief complaint of anxiety, that's less common. More common, patients presenting with somatic symptoms that may be anxiety manifestations or may go along with anxiety. And then patients with anxiety around their illness. All of these patients require a relationship that communicates empathy, acknowledges stigma, validates the patient concerns. That makes a huge difference. And always taking a complete history and laying hands on the patient, that is tremendously comforting to patients. And then the ask-tell approach to ask approach to diagnosis can be a very useful way for students to remember to do the complete collaborative enterprise.
Thank you so much for this information. We really appreciate it. And as you say, more people are presenting with these types of symptoms. So this is very, very important. If you're interested in a free 30-day DocCom trial subscription, no credit card is required, please email me, really easy, bal326@drexel.edu. And the recording will be on our YouTube channel very shortly. And please contact me if you would like the trial subscription. So thank you everyone for joining us. And thank you to Heather and Sonya for this wonderful presentation. Thank you.
Okay.
Hang on one second. I'm just going to